we go back 30 years ago when Professor Hcg, who is here with us today, published the first publication about the use of the GnRH agonist trigger in the context of ovarian hyperstimulation syndrome in an abstract that never caught attention because for those young among us, remember that those days everybody was using the GnRH agonist to prevent premature luteinization, so of course you cannot trigger with the agonist. But then later in the 90s came the GnRH antagonist to the market. So indeed the first publication of using the agonist on top of the antagonist protocol again came from the Rambam team in IVF in the year 2000. And that's of course stirred a lot of interest. And soon came some studies from Europe, also from Peter Humaidan's group, where they were triggering with the agonist and supplementing the luteal phase with a conventional protocol, and the outcome was disastrous. But then I had a chance to speak with Peter on one of the ASHRAEs, I think it was 2009, where we discussed it again, and we came to the conclusion that we need more things to do with it. It's not a done deal. So Peter came with the idea to create the GnRH agonist triggering group that indeed convened in Copenhagen in December 2009. And you can see the participants in this meeting. You see Professor Hcg here, Udi Margaliot, Peter here behind. You can see me here by Devoy, etc. And it was a very interesting meeting. And the fruit came a few months later with this publication, and this publication made a change. It appeared in 2011, and a few years later, according to the worldwide IVF website, you can see that almost 40% of cycles in Europe are triggered with the GnRH agonist. So we made a change, and we are part of it. So without further ado, I'd like to ask Peter to come to the stage. Peter is a good friend, a scholar, and a fantastic person to be with. So it's my privilege and honor to ask him to give the first talk.
Thank you very much. Dear colleagues, thank you. So to change the picture, is this one or? Yeah. Excellent. Do you think can I put my, no, it's okay. I've got a microphone here. Thank you very much. So, dear colleagues, but there's a microphone here. Yeah. So, can you hear me? Good. Thanks a lot for coming up early this morning on a Friday with us here. Obviously, for the ones of us who have been working together on this project, this has been like 24 hours in our thoughts. For me, long time also, for others even much longer time. So it's been like blood and tears. We really fought our way through the systems and criticism by colleagues. So it's like a political issue also over nearly 12, 15 years. Meta-analysis used to crush the idea of agonist trigger. Why? Well, I don't know. Political, pharmaceutical, I don't know why. Finally, as Shahar said, we are there now. We, for the sake of our patients, we now actually got there, which obviously was excellent. So I just want to get this one going. Okay, so I was asked to talk about personalized luteal phase support, and you will see there might be a slight overlap with some of the slides that Shahar gives you. But I'm going to look into luteal phase support as a whole, obviously based on the knowledge that we had from the agonist trigger. Now, so this is the outline of my lecture today. I'm going to go into early luteal phase physiology, look into the progestin support after Hcg trigger, and also, as Shahar was saying, that you cannot use the standard luteal phase support after agonist trigger. But just want to remind ourselves that just 14 years ago, we were very naive. It's just 14 years since we were using doing the first trial in which we were just using a standard luteal phase support after agonist trigger, and as Shahar said, obviously this didn't work. But we learned a lot from this failed study. Then I'd like to go into what we are focusing a lot on now, the role of mid-luteal progesterone for the outcome of an art cycle. And this is not just for fresh cycles, definitely also for frozen cycles. And I've got some new data to show you, and then finally come up with some conclusions. Now, just bringing us back to the old textbook. So this is the time that we're actually focusing on. And what I want to show you here, and just to remind us about, is the fact that at the time of implantation, around peri-implantation, this is where we had the peak of progesterone. But also, look at hydroxyprogesterone. No one hardly talks about hydroxyprogesterone, although it's actually quite active also, and the actions of hydroxyprogesterone are exactly the same as those of progesterone. I just need to get this stupid thing away. How do I get this one? End show, help. Okay. So, if we look into the luteal phase of physiology after ovarian stimulation with exogenous gonadotrophins, as soon as we reach more than 3 follicles, the levels of mainly progesterone during luteal phase will be so high that they will have a negative impact on the pituitary, which reduces LH significantly. And this is why we can say as soon as we start with gonadotrophin stimulation, we also mess up the luteal phase. We have, as you can see, supraphysiological levels of estradiol, but the most important thing is the supraphysiological levels of progesterone reducing the LH secretion. Now, this is the LH FSH surge during natural cycle. And you can see it's got a specific pattern with a long ascending limb, a plateau phase, and a long descending limb during natural cycle. So during this period of time, 48 hours, the total amount of FSH and LH will be secreted at the time of ovulation. Now, when we use Hcg, you can see the LH activity is supraphysiological, long-acting for a very, very high time, pushing the corpora lutea to an extensive progesterone and estradiol output, among others. So with the agonist, it's completely different, because you can see the surge, the duration is a total of 28 to 32 hours. And also, the shape of the surge is completely different, as shown in these early studies from Israel. You can see a short ascending limb of 4 hours, and then a long descending limb of approximately 24 to 28 hours. So the area under the curve of gonadotrophins, FSH and LH secreted, obviously is significantly lower after an agonist trigger. Now then, recently, some of our British colleagues from Royal College were looking into the use of kisspeptin, because, wow, this is a new drug, why not use this? And again, well, you have the shape, it's a 4-hour max, and then a very, very short surge of a total of 12 hours. So if the agonist trigger induces a LH deficiency, the kisspeptin is even worse. Now, just to show you, you can see kisspeptin works at the level of the hypothalamus, whereas the agonist will work at the level of the pituitary. This is actually the only difference. Another difference is that kisspeptin until now cost 4,000 euros for one injection, whereas agonist is very, very cheap. But we are very, very naive as reproductive endocrinologists. When we were trying to publish our first papers, we met a lot of resistance, even trying to get our abstracts through to ESHRE. When these guys, good colleagues from UK, presented their first data on 18 patients with kisspeptin, the lecture room was so full that people were waiting outside because, wow, this is new, this is innovative. They still face a lot of problems. They are modulating. They learned from our agonist-triggered cycles that they also needed to supplement the luteal phase completely different. I'm not sure that kisspeptin is going to be the future trigger. It's just moving one step up. The output the result of a search is the same, but the luteal phase is even more disrupted. Yeah, but they use it for research still. Yeah. Yeah. No, that's true. That's true. I'm sure. So, again, just to show you the differences between kisspeptin and agonist. So, the peak of kisspeptin after 4 hours is 40 units, and you're back to baseline at 12 hours. So only 40 units. Now, if we use the agonist, you can see the peak is 130, so nearly 4 times higher. And there's still 55 units around after 12 hours, and we are only back to baseline at around 28 to 36 hours. So just showing you the full pattern of these different trigger methods and the relative release of FSH and LH by the pituitary. So what about LH? Well, when I started research, I was looking a lot into LH follicular phase and the role or not, and the discussion is still ongoing. Which subgroups will need LH, who do not need LH? There's a lot of discussion. I don't think this discussion will ever end, but for luteal phase, there's no discussion. LH plays a crucial role, and obviously this is in terms of supporting the early corpus luteum until the implant itself by the LH activity in terms of Hcg will support the corpus luteum. Also, LH upregulates all the growth factors necessary for this implanting embryo to have vascularization in the endometrium. So this is VEGF-A and FGF2. And finally, we also have other cytokines like LIF involved in the implantation, also upregulated by LH. And finally, LH in luteal phase also stimulates the receptors involved in the embryo endometrial crosstalk, activating the Hcg receptor. So LH is pivotal for implantation and early luteal phase. Now, this is a very early paper by Filicori showing the correlation between LH and progesterone, obviously, because for each LH peak you see now during mid-luteal phase, this is a natural cycle. For each LH peak during natural cycle, mid-luteal, you will have a progesterone rise. So when we say LH in luteal phase, we actually also hint at progesterone. So LH and progesterone are very closely related there. So we all know the roles of progesterone. It's like transforming the endometrium into the secretory phase and regulating the window of implantation. But progesterone also increases vascularization in the endometrium. And progesterone, remember, works like an immunomodulator. So in the follicle, the oocyte is swimming in a big ocean of progesterone. So when the follicle bursts, the follicular fluid and the oocyte will be flushed down the tube with a lot of progesterone, also there working as an immunolator. And then, again, we all know that progesterone will reduce the contractions around peri-implantation, will secure quiescence of the endometrium, and thus secure that the embryo can safely implant. So, what about mid-luteal LH levels? Well, 6 during natural cycle, approximately, 6 IU. For the agonist trigger, you can see we had a reduction in this first study in 2005, in which we just used a standard luteal phase support. You can see the LH level was reduced by 75%, so very, very low. So what about Hcg trigger? So in the comparator group of that early study in 2005, we were using Hcg, and you can see, you could say, wow, LH levels were very, very low. So how come this works? Well, obviously, because we had a lot of Hcg around for at least 6 days after the trigger. So this is why the high estradiol, the high progesterone, would suppress the endogenous LH, but we had the Hcg around to cover up the LH deficiency. So this is what we all wanted to believe. When we trigger with Hcg, at least if we use like 10,000 units, you would have some Hcg activity resulting in progesterone activity around until the day of implantation, which is around day 8, where you will be able to measure, if you've got very, very good assays, you will be able to measure Hcg in serum at very, very low levels. Because from this time onwards, the LH needed to support the corpus luteum will be obviously provided by the implanting embryo. So, I mean, the circle is closed there, looks very nice, but then we have to ask ourselves, is this really the truth, the full truth? And again, an Israeli very early paper by Weissman looking into the pharmacokinetics of Hcg in 2 patients. These patients were hyper patients. And I'd like to show you that they were then administered 3 different doses and ways of dosing. So this is now 10,000 units subcut. This is 10,000 units intramuscular, and this is 5,000 units intermuscular. So you can see the pharmacokinetics depends very much not only on the concentration, but also the way of the administration. So this is obviously why we go for progesterone, for Hcg administration subcut, because we have the Hcg along in it for a much longer time. This is the first message, that administration plays a role. But have a look at these 2 patients and look at their levels. 2 individuals given the same amount of Hcg. Here you have, in this patient B, you have a peak of 1,200 units. And with the same dose in patient A, you have a peak of 300 units. Again, telling us that this is biology, these are patients, and our patients will respond differently to what we are giving them. Now, when does the embryo implant? Well, this is where the embryo implant, approximately 178 hours after the trigger. And you can see at this time, Hcg is going down, and so is progesterone also. It's not 0, but we are on a descending curve of progesterone at the time when nature would want the peak of the progesterone curve. So recently with Dr. Lan, we redid the Weissman trial because we wanted to look into further details. And you can see here, these are now 20 patients, and we were monitoring the early luteal phase after Hcg trigger. This is now Ovidrel, so recombinant Hcg. And what we were looking for were estradiol levels in level A, and then obviously Hcg levels. We also measured obviously progesterone and LH. Now, if we go for Hcg, you can see that the Hcg reaches its peak around 24 hours after trigger, and you will have around 130 IU in these patients as a mean. Now, for progesterone, obviously the peak is around oocyte retrieval +2. And then there's a plateau phase, and then we start decreasing. And this is now on the day of implantation. So you see the peaks of Hcg and of progesterone, and you also see the decline. So on ovum pickup +6, there's hardly any Hcg left, but obviously there's still a hangover effect on the corpus luteum, so there's still progesterone around. So what about LH? Well, obviously LH is extremely low, suppressed by high estradiol, but mainly because the estradiol, as you can see, is only very high here. Just telling us again, it's progesterone which has the most important effect on the negative feedback on the pituitary. So very, very low LH levels. Now, again, I just bring you back to this nice paper from Fauser and Devoy 2003, actually focusing on the same issue, that there are significant differences in luteal phase if we compare the normal cycle to that of the hyperstimulated cycle. So the surge is significantly earlier, and this obviously will create some kind of asynchrony in the endometrium. So what we tried to do over the years was actually, we want to avoid this high peak. How can we do this? Well, with an agonist trigger, obviously. But then we need to restore functions. And what we're doing now, and I know of colleagues here who are trying it also, we're trying to mimic more the natural cycle in which the peak will be around implantation. So this is the idea of the luteal phase support. This is where we want to be. We don't want to have the peak here. And this, this is something different, but I just want to tell you. Now, all over the years, we heard about this detrimental 1.5 nanogram per mil late follicular phase progesterone level, which more or less was invented from a database in Brussels. And it's been supported, or it's not been supported by different trials. And everyone was so focused on 1.5 nanogram per mil, well knowing that 10 hours later, progesterone will be 10 times higher. So I always found it very difficult to understand, why does 1.5 nanogram per mil play a role at all? Because 10 hours later, it just rises like sky high. So, and this is hypothetical, but I think this is a very good hypothesis. This was my colleague from Denmark, Hcg Andersen, who suggested, okay, patients with high late follicular phase progesterone are usually either patients with many follicles or patients who were really pushed with high FSH dosing, high LH, high Hcg, because all these gonadotrophins will induce progesterone production not only from the granulosa cell, but also from the theca cell. Now, if you use a lot of FSH in your patient, you induce LH receptors on the granulosa cell. So, once you trigger in these patients who had a lot of FSH, who were producing progesterone, which you could see in the late follicular phase, they have now many LH receptors, more LH receptors activated. So once you do the trigger, you will have a significantly higher, it goes up like this, a significantly higher peak at an earlier stage in a patient with high late follicular phase progesterone as compared to a patient with low. So late follicular above 1.5 is just a proxy for what is the real problem. The real problem is the surge following if you use the Hcg trigger. Now, we analyzed some of our data, and it's quite obvious that this is what's actually go on, because we can see a profound difference whether patients were low in progesterone here or whether they were high. This will be depicted in their progesterone curves after the trigger. So, then, you know, we were told in the early days that we don't care about serum progesterone because it's only local which has an impact. But is this really true? Because, you know, some of our US colleagues have been monitoring late or mid-luteal phase progesterone levels, and they saw that these actually were quite good markers of endometrial receptivity. So recently, very recently, there was this very nice paper, I think it's from US also, anyway, a pilot trial in which patients were administered IM progesterone in different doses, as you can see. So either 40 milligrams, 10 milligrams, 5 milligrams, and 2.5 milligrams. And here you see the serum progesterone in nanogram per mil according to the dosing used. Now, here you see the correlating histology. And the interesting finding here is that regardless of whether patients were controlled during a time of ovulation or these patients were administered progesterone in different doses, the only non-receptive endometrium was the endometrium which had the lowest dose, 2.5. All the others were, the histology told us that this endometrium is receptive. But if you go into gene expression, you will see that the picture is completely different. Only the patient who had the highest progesterone, circulating progesterone in serum, actually had genes depicting a receptive endometrium as shown with the controls. So, what is going on in serum is actually a very good, or even better marker of the receptivity and the gene expression in the endometrium at the time of implantation. Now, so we can say from the old papers by Weissman and also the new stuff that we did in Vietnam that, well, maybe this is more realistic. to say that, well, we've got Hcg around until 6.5 days, specifically if we use lower doses for Hcg trigger. And then we have like a descending curve, so there will start being some LH activity deficiency, and also still some progesterone, but progesterone is creeping down at this stage around the time of implantation. So where do we actually need the support? Well, obviously we just need the support around implantation, because once this embryo implanted well and Hcg is measurable in serum, we don't need any more progesterone, because the embryo itself obviously will support and we will have the corpus luteum function. So in reality, we just needed the progesterone support once the efficacy of the Hcg trigger starts to decline. And this is approximately 8 days in a normal Hcg triggered cycle. Obviously, none of us did this. But from a physiological point of view, this is the reality. We tend to be very practical in reproductive medicine, so we'd rather overdo. And it's also easier to tell our patients you start the day after the pickup and you continue until week 8, 10, 12, 15, 30 or whatever. But in reality, this is definitely completely non-physiological. So for Denmark, and this is now for all of Scandinavia, since we had this prospective trial in which we either continued our luteal phase support or we stopped the luteal phase support on the day of the pregnancy test. And you can see that the delivery rate is exactly the same. The early pregnancy loss rate is exactly the same, regardless of whether you continue or whether you stop your luteal phase support on the day of the pregnancy test, which is usually like 14 days after transfer. So this completely changed our policy. So Scandinavia, the standard patient with no previous early pregnancy losses, etc., all our patients stopped their luteal phase support on the day of the pregnancy test. And there's a good physiological rationale to do so. So, now, again, we heard about the detrimental, or not detrimental, we heard about the negative effect of our multiple corpora lutea, the progesterone, and low LH levels. Then imagine we use the agonist trigger. And I showed you how the area under the curve of LH is significantly reduced by agonist trigger. So we now add a double negative factor to LH. And this is why we ended up with 75% reduction in circulating LH after agonist, because we have multiple follicles and we had a short duration of the surge in combination. So this is what it looked like after agonist trigger. We had a rather long LH activity deficiency period during which these embryos were left more or less alone, and they tried to implant because biochemical pregnancy rates were actually quite acceptable, but we lost all pregnancies. They just implanted and they had to give up because there was no VGF, no LIF, nothing around. So we lost nearly 80%, 80, in that early study in 2005. So at the same time, this was prior to the clinical trial era, so we didn't know what someone else was doing. They were doing exactly the same trial in Brussels. Luckily, we were the first to publish, and 3 months later, they came out with the same results. Agonist trigger with a standard luteal phase support does not work. High early pregnancy loss. So at this stage, I think, again, we had the typical, let's say, non-scientific criticism. So it doesn't work, forget it, and let's move on. But we were quite curious because we wanted to know what is the reason for this. And we did a lot of studies in follicular fluids from this 2005 study. And what we saw was that the steroids of the follicular fluid were at a much more physiological level in the agonist-triggered cycle as compared to the Hcg triggered cycle. So beneficial surrounding for the Ohs side. We also compiled all the data from Brussels and Ohs with this paper with George Griesinger, in which we were looking into the reproductive outcomes of those embryo deriving from the 2005 cycle study, which went into the freezer. Excellent reproductive outcomes. And then we also looked into amphiregulin, which is a mediator of LH inside the follicle, and we could see that with the agonist trigger, we had much more physiological amphiregulin levels, and like everything else in biology, there's a ceiling and a threshold, and if you go above the ceiling, there's a negative impact. And this was shown by Japanese colleagues also, that in some Hcg-triggered patients, you actually reach the ceiling of amphiregulin and implantation rates are lower. So just to sum up, all these additional studies told us, well, there's nothing with the egg, there's nothing with the follicular fluid, there's nothing with the embryo. The problem is once we transfer the embryo in this fresh cycle. And looking into LH, we were saying, well, this must be the reason. So long LH activity deficiency period, what can we do to rescue this? So this was the next study trying this hypothesis, and we empirically we suggested 1,500. Some of our Spanish colleagues years ago used 1,500 in IUI patients, and we wanted for these IVF patients to give them just a little bit of HCG, not enough to induce OHSS, but still enough just to rescue part of these multiple corpora lutea. We didn't want to rescue too much because then we would run into OHSS. We just wanted to rescue a little bit until the embryo would implant and take over the production of HCG. So over the years, you can see we did these randomized trials. This is the first trial in which we obviously monitored progesterone levels. And I just want to show you how progesterone levels changed and what the change in progesterone actually did to our reproductive outcomes. So this was the first study, only standard luteal phase support. Then the next study, we added a bolus of 1,500 on the day of ovum pickup. We also used vaginal gel, but we probably didn't need to use it, but obviously we didn't want to change. We just wanted to change one parameter, which was here, the HCG. And then finally, in a more recent study, we tried in patients who were not at risk of OHSS to add another bolus of HCG around time of implantation on the blastocyst transfer day. So what did this do? Well, you can see we were manipulating with serum progesterone levels. So from the first study, we had 39 nanomolar, and this was actually just the exogenous. This is what you get by approximately 2 crinon. This was crinon we were using. This is 39, 32, just telling us that these corpora lutea were completely taken out. Then in the second study in 2010, adding one bolus of 1,500, we actually were able to nearly double the circulating progesterone and look at the reproductive outcomes or the pregnancy losses. Here, with the standard, we lost 79%. Here, just 21% just by adding some LH activity. And the good message here was obviously, okay, this was the right hypothesis. This was the right thing to do. And then here further, obviously this is a small study, but it seems as if by adding even more during luteal phase, we could further decrease the early pregnancy loss. And here you see the clinical or rather ongoing pregnancy rates, because most of these ultrasounds were performed in week 10. So again, showing you how mid-luteal progesterones prior to implantation actually correlate very, very well with ongoing pregnancy. So Shah also always had the idea, we want to get rid of the vaginal support. What can we do to do this? And he will show you some of his trials. What we did, we came up with the idea of using an agonist trigger and then daily low-dose HCG. And we chose 125 units daily. And this was very complicated because this is recombinant HCG. So we had to dilute every day, take a new Ovidrel pen every day, and dilute, and then add 125 and nothing else. So agonist trigger, standard IVF, and 125 and no vaginal. Again, it's a pilot, 30, 30, 30. These two groups were the groups who had the daily Hcg support. And this is then an Hcg triggered control group. So what you see here again is that this works excellently, guys. If I can just get the pointer there. There you see the implantation rates are very good, and so are the clinical pregnancy rates with no vaginal at all, just boosting the endogenous. And mind you, it's not just progesterone, it's also all the other cytokines produced by the corpora lutea that we activate. So this is an endogenous progesterone and corpus luteum boosting the endogenous function, which at the end of the day probably is more physiological than anything else that we give from outside. And look at the serum Hcg levels. Giving 123 units a day, 125 units a day, resulted in a mean Hcg level of only 3.3 units. So very, very physiological. But this 3.3 was able to boost 100 nanogram per mil from the corpora lutea. So very, very little Hcg and full activity of the corpora lutea. So recently with one of our colleagues from Algeria, I tried to refine the protocol further by adding, like others also do here, Bahava, I tried to add one bolus of an agonist. So I used our protocol with the 1500, and I said, well, I want to avoid too much Hcg, so why not just add a bolus of decapeptyl on ovum pickup plus 6. So two groups of patients, one our protocol only, and the other one our protocol with this bolus of decapeptyl. You can see these are more or less normal responder patients. You've got the number of oocytes for the control and the day 6 decapeptyl group. And here, and obviously for us this is interesting to see because you can see the signs of the decapeptyl injection because they were administered decapeptyl on day 6. We measured on day 7. And you can see a significant increase in FSH, in LH, in estradiol, in progesterone also. So this small bolus really boosted, made a difference actually. So did it change anything in terms of pregnancy rates? Well, it didn't, but it's interesting to see that we seem to have, like, it's non-significant, but it's interesting, a higher Hcg production from the decapeptyl triggered or boosted patients, probably suggesting that the implantation was facilitated by this increase in progesterone just around implantation, resulting in a better Hcg production. So what about the reproductive outcomes? Well, I think they're quite excellent in both the standard agonist trigger. This is fresh transfer agonist trigger. Delivery rate of 36% is very nice. Miscarriage rate is fine. Interesting again, non-significant, but there seems to be a reduction in miscarriage in those patients who had a little bit of decapeptyl on the day of ovum pickup plus 6. For OHSS, did we see any OHSS? Yes. We are very honest. They were not severe, so others would never report these in their trials. But we have to be very consistent. This was moderate, 1 in each group. Even in patients with 12, 13, 14 follicles. And we know this from our daily practice. The follicles are a good marker of the risk of OHSS, but it's not, you cannot always tell who's going to have OHSS. And this is moderate. So no hospitalization, no intervention. So let's now look into this increasing amount of frozen embryo transfer cycles, which we are all doing. And we all believe that one size fits all, because this is what we did with the fresh cycle. So why not just continue with the frozen cycle? We don't need to think. We just continue the way we did now for 20 years. Now, we learned a very tough lesson in 2011 when reanalyzing our data, because in those days, this was a little bit prior to the introduction of vitrification, in our unit at least. So, well, we had some pregnancies from our freezing program, but they really, it was just like a supplement. Now, like you, we get a huge amount of live births from our from our frozen embryos. So there's much more focus on the efficacy of our, not only the vitrification, but also the luteal phase support. Anyway, we looked into our database, and you can see this is now a retrospective analysis comparing two periods. In the first period, we used 1 vaginal gel a day, as suggested by the provider in luteal phase support. During the next period, we used 2 a day. And look at this. We had nearly a tripling of the implantation rate. The pregnancy rate significantly increased. The delivery rates were nearly tripled just by adding 1 more vaginal progesterone. And you can see also a significant reduction in early pregnancy loss. Again, we're just manipulating with progesterone. Excellent embryos were left in a surrounding with too little progesterone and a lot of biochemical pregnancies and a very, very low delivery rate. So, 2015 we had this paper from Jovic. It's again a retrospective analysis, but the interesting thing here is that he was looking into patients who had single embryo transfer, good quality blastocyst, and there in Australia they use an extremely intensive luteal phase support. Look at this. Oral estradiol, vaginal progesterone, 400 milligrams 3 times a day. A lot of estradiol, a lot of progesterone. So obviously he was doing was blastocyst, so transfer on day 6 of progesterone, and then he was measuring serum on day 8, in which you would definitely have a steady state of not only the estradiol provided, obviously, but also the progesterone. So I think the first important message is here, estradiol, progesterone. Look at this. These are patients who are treated with exactly the same regimen. And look at the huge difference in levels, despite patients have the same progesterone and estradiol. So from 13 to 260 nanomolar with the same regimen, and from 300 to 12,500 picomolar with the same estradiol regimen. So one size definitely does not fit every patient. So did this show in their reproductive outcomes what the resorption was? Well, actually it did. You can see here he tried to come up with some cutoff levels for these frozen embryo transfer levels. And he was suggesting, well, we should be around, at least with his assay, we should be around for clinical pregnancy, but also for live birth. There seems to be like this typical bell-shaped curve in which you have a maximum around 70 to 100 nanomolar. So this was his message for this paper. Then last year from EVI, our colleagues were looking into oocyte recipients. Again, blastocyst, single blastocyst transfer, a more, let's say, standard regimen, oral estradiol. I think they use 6 milligrams also, and then progesterone vaginal, and then transfer and measurement on day 6, so on the day of the transfer. So what did they show? Well, they saw more or less the same, although the cutoff for, let's say, success is lower. It's around, you can see, 9.2, 9 nanogram per mil. How wonderful. We're just back to the old textbook. This is the production from what we would usually say was 1 corpus luteum. So quite understandable. And if you look at it, you would see 25% of these patients had lower levels than the 9 nanogram per mil, which resulted in a significantly lower ongoing pregnancy rate. So nearly 17 to 20% lower ongoing pregnancy rate just because of the luteal phase support. And they concluded, well, if you're too low, despite you had this excellent regimen, which you believed, which was excellent for all patients, if you're too low, and 25% of our patients are too low in this study, well, your live birth rate, delivery rate will be significantly lower. And then we have the typical criticisms, and they would say, oh, but these were oocyte recipients, they were old ladies, and we can't compare those to our IVF patients. But this is not true. This is now a paper from our group in Press, RBMO, retrospective, but again, excellent 244 single embryo blastocyst, high quality blastocyst transfer, all patients treated with the same HRT regimen, and blastocysts were vitrified on day 5 or 6, and we measured serum progesterone on the day of Hcg measuring here. And you could say, why did you do it this day? Why didn't you do it earlier? Well, for us, actually, it doesn't play any role when you measure. Now, with the knowledge we've got, we're going to measure earlier, because what we want to know, we just want to measure once we have reached the saturation in serum, and you will, with progesterone, you will be up there in a few days. So you could actually measure already after 2 or 3 days, and you will know that this will be the level that you will reach with this specific regimen. Anyway, 244 patients, and look at this. We see exactly the same in our patients. Here with us, we found more or less the same, 11 nanogram per mil. So lower, you have a lower ongoing pregnancy rate. And just to show you, we lose 14% of our pregnancies of these excellent blastocyst transfers if they are lower than 11 nanogram per mil. I just talked to Ernesto Bosch some weeks ago, and they were reanalyzing a much larger cohort, and they see exactly the same, a 17% loss if you are lower than 11 to 12 nanogram per mil. So, just to conclude, well, there is definitely a lower cutoff, and we know this from nature also. And this cutoff obviously should be there at the time of implantation. For fresh cycles, we learned from our agonist-triggered cycles that the lower cutoff level is around 100 nanomolar. In frozen cycles, well, until now, we came up with this cutoff level of 11. What I forgot to tell you was that 50%, half of our patients, are below 11 in this study, which really made us rethink and go into this whole idea of monitoring the luteal phases, not only of our fresh cycles, but also our frozen cycles. About the ceiling, well, in the fresh cycle, it's definitely very, very high. For all luteal phase support, we know that we need luteal phase support during the early to mid-luteal phase of our fresh cycles. But then after implantation, someone should do the trial that they just stopped a few days after implantation, which would probably work very nice. At least we know that the study is around showing that you could stop on the day of the pregnancy test. Again, there is a correlation between mid-luteal progesterone levels and ongoing pregnancy in fresh and frozen embryo transfer levels. So serum progesterone is a very, very good marker, not only of endometrial receptivity, but also of the conditions that we transfer our blastocyst into. So I think instead of these endless monitoring, follicular phase, estradiol, progesterone, FSH, etc., which we took away in Scandinavia 15 years ago, we don't monitor anything during follicular phase. We monitor by ultrasound, and that's it, the endometrial thickness. We don't believe in estradiol measurement, etc., etc. We do our own scans like you do. But I suggest that the resources spent with all this endless blood sampling in follicular phase would be better spent in luteal phase monitoring, because this is where we can really change the pattern and the outcomes for our patients. So for luteal phase, we are still walking on a very, very thin line, and there's a huge amount of, we need a huge amount of data to learn something about the luteal phase. And when we say today that 60% of PGS screened top quality embryos implant, also tells us that 40% do not implant. And I think we should ask ourselves, maybe, and I suggest there are quite a few things we could do to increase the number of implanting blastocysts. One of those would be monitoring the luteal phase for progesterone. So this is my staff. I'm a guy here surrounded by a lot of ladies. And without these ladies, I couldn't be here with you today. So thank you very much.